I'll give a small introduction about the retropharyngeal space. So, these structures are the tonsils. This is a drawn picture. So the space behind the tongue, this is the pharynx. I'll show you a side view also so that you have a better idea. This is the tongue, the tonsils will be here, and this is called as the pharynx. And the area behind the pharynx, retro means behind the pharynx is the retropharyngeal space. So if it's chronic, the most common cause will be secondary to tuberculosis of the cervical spine. That's the commonest cause for chronic retropharyngeal abscess. Now, the retropharyngeal abscess, it is seen between the buccopharyngeal fascia and the prevertebral fascia. Orange colored thick one is a prevertebral fascia. True retropharyngeal space is between the buccopharyngeal fascia and the alar fascia. So the alar fascia divides into anterior and posterior. The anterior one, it extends from the base of the skull up to T1, blends up to T4 vertebrae. But the posterior part starts from the base of the skull, it goes beyond the T4, way down, the posterior mediastinum. That is the difference. And the retropharyngeal space has got communication with other spaces in the neck too. That is the clinical significance. I'll come to it. Now, the commonest complaint of the patient will be they have been having night sweats, evening rise of temperature for a long time, say for months together, and they have lost their weight, and off late, and that too for months together, they have difficulty in eating. Something as if something gets stuck in the throat. Not only that, they have mild swelling in the neck. I'll tell you the reason for that also. And they have pain which starts from the neck and goes down the arm. On examination, they'll be having enlarged lymph nodes in the neck. Oropharynx, we can see there's a central bulge, but it is not congested, it is not red in color, a single big bulge in the center, or it can be on the side alone. Why the difference? I'll tell you that. This one is secondary to the abscess formation, secondary to the TB spine. And in this, the later one, the bulge is because of lymph node with enlargement secondary to tuberculosis. So the most common one will be this one, central bulge. So you have two types, central bulge or lateral bulge. Coming to the investigation. When we do CBC, ESR and C-reactive protein, generally the ESR will be elevated. To start with, we'll take an X-ray neck, but for sure the golden standard being CT scan neck and inclusive of the chest. And chest X-ray, but suppose CT scan chest is done, chest X-ray can be avoided. Now, in the X-ray you will find findings suggestive of tuberculosis, and we'll go ahead and do a Mantoux test, where a purified protein derivative will be injected intradermally in the inner surface of the forearm, and it will be the induration will be read after 2 to 3 days, and they'll give the report. We need sputum for AFB stain and PCR CB NAT study, and it had the morning, we need a morning sample that took for 3 consecutive days. Suppose the patient doesn't have sputum, he doesn't have cough, in that case, we need to do a bronchoscopy, do a bronchial lavage to get the sputum, and with that sample, we'll go ahead and do a AFB stain, Zeal nasal stain, and PCR study, CB NAT study. Likewise, we'll aspirate from the swelling, posterior pharyngeal wall abscess, and we'll send it for lab for normal gram stain, and not only that, AFB stain and PCR study for CB NAT. And one more test, blood test, is quantiferon TB gold test. So in this CT scan, we can see there's an abscess formation. Not only that, the cervical bone, it is destroyed here and it has lost, it has become straight too. Now coming to treatment. As there is abscess formation, the abscess has to be drained. But unlike acute retropharyngeal abscess, in chronic retropharyngeal abscess, always the drainage is external. And the patient need to be in the hospital for 2 to 3 days. Most probably on the 4th day, you will be discharged with a course of antibiotic and painkiller and vitamins. You need to consult the orthopedician also, because all this has started, it is secondary to TB spine, cervical spine. So maybe the orthopedician, they'll plan for cervical spine sequestrectomy, and that will be an elective surgery, not to be done at the same time. Elective surgery. And by about 5 to 7 days, all the reports, lab reports will be ready, and you will be referred to TB center, your regional TB center, where after analyzing all the report, they will start on anti-TB regime, which is usually for 6 to 9 months. So that is how we manage a case of chronic tuberculosis, chronic retropharyngeal abscess. I would like to mention one more thing. See, after surgery, when you are discharged after 4-5 days, if you develop any of these complaints, you have to rush back to your doctor at the earliest. These are high fever, difficulty in swallowing, neck stiffness which has increased, and breathlessness. Why? Because there is a possibility that after surgery, there is a recollection of abscess. The possibility is there. So, in case you develop any of these, it's always better to get it reconfirmed. You have to rush back to the doctor, the surgeon, ENT surgeon who has operated on you, get it reconfirmed, and if needed, you need to be operated. But usually, it's not that common to recur. So that's how we manage a case of chronic retropharyngeal space abscess. Thank you so much.